Everybody, Dr. Carlo Oger, board certified emergency physician with DrER.tv. In this video directed at the healthcare professional or healthcare oriented people who want to learn about medicine, we're going to be showing a rash clinical picture, and then we're going to discuss it and then show you a whole bunch of other pictures of the same rash in other patients so that it can really anchor in what it looks like and what the discussion is. Reason I wanted to do this is because honestly, some rashes are very difficult. They show up different ways, and sometimes people show us a rash and we have no idea what it is. So I figured if I do one of these every week, both you and me can learn together and get better at recognizing some of these dermatologic disorders. So let's talk about the clinical picture. A patient presents with clusters of confluent and extremely itchy pruritic papules and vesicles on the exposed chest. Onset 1 day following the first sun exposure of the season. She also had it in the dorsum of the arms but not the hands. So that's the clinical picture. Basically a rash that is very itchy, happens about a day after the exposure to sun, and it's usually confluent papules and vesicles. So let's look at the rash. There it is. I mean, it very, very small papules, vesicles. Mostly you see that redness on the V part of the chest. So I would say, it's some kind of sun reaction or maybe a dermatitis. And normally I would just give the patient some local steroid cream and discharge the patient home with follow-up and observation. That's what I would do. I call it some kind of dermatitis, sun-exposed dermatitis. Well, it's not entirely wrong, but there's a better way to call this. It's polymorphous light eruption, or PMLE, polymorphous light eruption. It's idiopathic. That means we doctors are idiots and we can't figure this out. It's more common in female, almost 3 to 1. It is acquired. That means that it wasn't there when you were little. It kind of, as you grow, it starts showing up. And there's usually about a 50% family history of the disease. It's an acute and it's a recurrent photodermatosis. That means it's a sun or sun-exposed disease of the skin. And it is a delayed reaction to UV light, and most specifically UV light type A as opposed to UV type light B. Many patients can also experience a little bit of lethargy, chills and headache and nausea starting 4 hours after the sun exposure, and it can last like usually 1 or 2 hours. So they get acutely feeling ill before the rash develops. Most common presentation is the papula and the papulevesicular eruption, and is very itchy, and the medical term was pruritus. Face is rarely involved, but I looked around and there's some pictures of people with this kind of photodermatosis on the face, but it's more common on the V part of the chest as it's exposed. Once it happens, it lasts 7 to 10 days. And the treatment's gonna be mostly topical steroids, okay? So you do the topical steroids, so even though I didn't know the name of the disease, I would have ended up treating it the correct way. Some people who have the history of it, before the spring comes, before summer comes, they can have a 4-week period where they have 3 times a week photochemotherapy or PUVA. So that helps build some tolerance, and therefore the rash is not as bad once they finally do get exposed to the sun. Obviously, avoiding sun when the sun's really hot, noon hours, that would be great. That will decrease that, keeping themselves covered and things like that. And for those who do not respond to the topical steroids, the PUVA, then you can use hydrochloroquine, 200 milligrams twice a day. Now, this is an anti-malarial drug, became very famous in the last year or so with the COVID. So you could try that. So polymorphous light eruption, or PMLE, photodermatosis, more common in females. History of family of the same thing 50% of the time. Papular and papulovesicular rash, very itchy, and lasts 7 to 10 days. Now let's look at other pictures. That's the photodermatosis right there with vesicles and smaller papules. There it is, mostly papules and no vesicles all over the exposed back. Again, V part of the chest. Here's another view of the chest area of this photodermatosis. A little more pronounced, lower extremities. And that's more of the same. So hopefully this one doesn't look like that. To be honest, it almost looks like psoriasis or something like that. But the history is very important. The fact that it goes away during the winter, comes back around when people are exposed to sun in the spring and early summer. So here are some pictures to anchor this diagnosis. PMLE, polymorphous light eruption. Happens more in spring and early summer. Targets the V part of the chest, more common in females. Family history is idiopathic. Treatment steroids, PUVA, and hydrochloroquine if nothing else helps. Hey guys, I learned a lot making this video. I hope you learned too. We'll try to do one of these every week until we're experts at rashes. How about that? We'll see you in our next video. Bye-bye.